Hi everybody, and welcome to our module on local anesthetics. Local anesthetics are drugs used to provide local anesthesia, meaning they are used to block conduction in pain nerve fibers to anesthetize a small portion of the body, like an area of skin or a hand or a foot. They can be divided into two classes: the amides, which include drugs like lidocaine, mepivacaine, and bupivacaine, and the esters, which include drugs like procaine, cocaine, benzocaine, and tetracaine. And you may know that cocaine has effects on the autonomic nervous system. That is separate from its effects as a local anesthetic. It has both properties. It can modify sympathetic nervous system activity. It can also provide local anesthesia. And at the top right side of the screen, I've shown the general structure of these drugs. You can see that the amides are at the bottom and the esters are at the top. They are very similar, but the amides have a nitrogen here and the esters have oxygens. All local anesthetics are weak bases. So what does that mean? A base is a chemical compound that likes to accept a hydrogen molecule. So this is a base right here bound to a hydrogen molecule. But in the bloodstream, there's an equilibrium between what's called the protonated form. Over here, it's got a hydrogen, which is a proton attached to it. And over here, the unprotonated form of the base. This unprotonated form of the base can cross the cell membranes of neurons to get inside the cell. Once it gets inside the cell, it binds a hydrogen atom inside the cell and becomes protonated, and then it's trapped because this form can't go out. And this protonated form of the weak base of the local anesthetic will bind to the interior portion of the sodium channel, and it will block sodium from getting into the neuron. And you may recall that sodium getting into neurons is essential for depolarization. So when these drugs block sodium channels, they make it harder for cells to depolarize. And that means it's harder for the neuron to send pain signals back to the brain. So I've summarized the key points that you should remember down here. It's the uncharged form that crosses the membrane. The charged form blocks sodium channel. Drugs work on the inside of the cell membrane. And then a fourth point here is acidic environments make the drug less effective. So acidic environments have very high proton levels. For example, infected tissue is very acidic and has lots of protons. It will drive the local base this direction to be protonated, and this form cannot get across. So when you use a local anesthetic in some infected skin, you need to use a higher dose of the drug because of this phenomena. Sometimes you'll see local anesthetics given with epinephrine. For example, lidocaine with epinephrine is often used to inject sites that are going to be sutured. This causes vasoconstriction, and that means that there'll be less bleeding. It also causes vasoconstriction, which means there's less washout of the lidocaine, so you get more anesthesia. Local anesthetics exhibit a property called differential blockade, and this means that certain types of nerve fibers are blocked more effectively than others. So small fibers are more blocked than large fibers, and then myelinated fibers are more blocked than unmyelinated. And you might wonder why this is true, but if you remember, axons have something called nodes of Ranvier between myelin. So if this is myelin and myelin here, there's a node of Ranvier right here. If local anesthetics block the sodium channels here, they've essentially blocked this entire length of the neuron. So the myelinated axons are very dependent on those nodes of Ranvier, and just blocking a few of them causes significant decrease in the ability of the neuron to send signals. And that's why myelinated fibers are easier to block. So I've written the order of the block down here. The first thing to be blocked are small myelinated, and then small unmyelinated, then large myelinated, and then large unmyelinated. Because of the different effects on different nerve fibers, there's different effects on the senses. So pain gets blocked first and pressure gets blocked last, and I've shown that down here. And if you've ever been to the dentist and had Novocaine injected into your jaw, you know that you can't feel pain, but you can feel the dentist's fingers pressing on your jaw, and that's because pressure is the last thing to go and often remains even after pain has been blocked. There are two general situations where you'll most commonly see local anesthetics used. The first are minor surgical procedures. So for example, if someone is getting a wound sutured in the emergency room, the wound will often be numbed first with a local anesthetic so the patient doesn't feel any pain while you're stitching it up. And then the other place they're commonly used is epidural and spinal anesthesia. So in spinal anesthesia, a needle is inserted into the spinal canal and a local anesthetic is injected, and this produces numbing from the abdomen down, and this is done for women when they're having babies delivered by cesarean section. A similar and somewhat related procedure is to slip a catheter into the epidural space and provide continuous infusion of a local anesthetic, and this is another way for numbing the waist down in women who have cesarean sections. Side effects from local anesthetics are fairly uncommon because normally they're injected locally and they don't reach other parts of the body to cause a side effect. When side effects do happen, it's usually because someone injected too much of the drug or accidentally pierced an artery and then injected the drug. If the local anesthetic reaches the central nervous system, it can initially cause patients to become excited. They can start to talk, get anxious, be confused, have stuttering speech. They can just look highly agitated. And then later they can become drowsy and potentially go into a coma. This is very, very uncommon. And then if these drugs reach the cardiovascular system, they can block sodium channels in the heart. And some of the local anesthetics, like lidocaine, are also used intravenously as cardiovascular drugs to combat arrhythmias. So if the drug reaches the heart, you can see hypotension, arrhythmias, bradycardia, and heart block. And this is all from blocking the sodium channels in the heart. The one exception is cocaine. It's a local anesthetic, and if that gets into the body, it will cause hypertension and vasoconstriction because it blocks norepinephrine reuptake at nerve terminals. And bupivacaine, you may get asked this on your boards, is the most cardiotoxic, so that's just a little tidbit that you should know. Finally, let's talk about an important side effect of local anesthetic drugs, and that is the side effect of methemoglobinemia. So recall that iron in hemoglobin is normally present in the reduced Fe2 plus state, but there are certain drugs, including some local anesthetics, that can oxidize iron to the Fe3 plus state. When Fe3 plus iron is present in hemoglobin, we call that methemoglobin, and normally there's a very small amount of this present in your plasma. Usually it's less than 1% or so of all the hemoglobin, but certain drugs can raise the percentage of methemoglobin to 10 or 20 or even 50 or 60%, and then patients can get very sick. The problem with methemoglobin is that Fe3 plus iron cannot bind oxygen. In addition, it modifies the remaining Fe2 plus iron so that it cannot release oxygen to tissues. This is a very bad combination. It essentially creates a functional anemia where patients either cannot bind oxygen, or if they do bind it, they cannot release it. There are several drugs that are classic for causing an acquired methemoglobinemia, and these include local anesthetics like benzocaine. It can also occur after exposure to nitric oxide. This can happen to premature babies who are given nitric oxide for vasodilation. There's also a rarely used antibiotic called dapsone that can cause this complication. The treatment is a compound called methylene blue, which quickly converts the Fe3 plus iron back into the Fe2 plus state. So a classic clinical scenario to know is an endoscopy patient who has just had a camera inserted into the throat for diagnosis. Benzocaine spray is often used for throat analgesia. Post-procedure, the patient will complain of shortness of breath. High levels of methemoglobin in the blood turn the blood chocolate brown in color. So if the patient has a blood draw for a blood gas or a venipuncture, it will be described as having chocolate brown blood. The oxygen saturation by a pulse oximeter is unreliable in the setting of methemoglobinemia. It can show results that are variable anywhere from the 80s or 90s, and that's because the methemoglobin interferes with the device. If you do a blood gas and measure a PaO2, it will be normal, and that's because there is plenty of oxygen in the blood. The problem is it cannot bind the 3 plus iron, or if it binds the 2 plus iron, it cannot be released to tissues. This complication can also occur to premature babies, as I said before, who are given nitric oxide for pulmonary vasodilation. And that concludes our module on local anesthetics.